Other effects of ARNI includes reduction in the left atrial volume, left ventricular volumes, troponin levels, markers of fibrosis, mitral regurgitation in PRIME trial. It's a very interesting trial, and ventricular arrhythmias, which I already mentioned. Now coming to kidney, we know that heart failure is independently associated with GFR decline, and ARNI compared to ACE inhibitors reduced the rate of decline of GFR. So that is important. Even more important for Indians is that there was more than twice the benefit in diabetics, and majority of our patients are diabetics. It's again a very recent paper in April 2024. They looked at patients with various KDIGO scores, low risk, moderate risk, and high risk. And they found that Valsartan sacubitril was well tolerated and exhibited consistent cardio-kidney protection across the continuum of kidney risk. And this is one of my favorite slides. I keep repeating it because even though we know the benefit of ARNI, in India, the usage is maybe around 4 to 6% of eligible patients. And commonest reason is we are worried about the kidney function. So if the delta creatinine is less than 50 or the maximum creatinine is less than 2.5, minimum GFR is 30 or above, or maximum potassium is 5 or below, action advised is uptitrate and reevaluate the renal function. When you reach red is when the creatinine has increased more than double, creatinine, the maximum creatinine is more than 3.5, minimum GFR, eGFR is less than 20, and potassium more than 5.5. For practicing people, like up to a creatinine of 2.5 and a potassium of 5, you can easily give ARNI, you can uptitrate ARNI. This is not commonly followed in our country. One of the important thing was about potassium. Is it a hypokalemic drug? No, it is not, but it has got some protection. See here, MRA plus ARNI had less hyperkalemia than enalapril alone without MRA. MRA we know increased potassium. So here the combination had less potassium than enalapril alone without MRA. What about uric acid? We know there's a lot of controversies, or we do not know whether it's a bystander or an active partner in crime. But what we have seen in the paradigm trial was that people who had the highest uric acid did the worst. And sacubitril valsartan reduced uric acid both in HFrEF and HFpEF paragon. What about HbA1c? We keep on hearing about GLP-1 receptor agonist, but one of the substrate for inflammation is GLP-1. So sacubitril valsartan increases GLP-1 levels. That is why there's a reduction in HbA1c and substantially reduced likelihood of new insulin use of patients with type 2 diabetes. What about anemia? We all know that anemia is bad. We have seen that people with anemia do much worse. And the interesting thing is both ACE inhibitors and ARBs that produced a reduction in hemoglobin. They produced anemia. Whereas like the valsartan sacubitril acted at two levels, substance P as well as what is called as SP1 to 4, and reduced anemia. There was less new anemia. So that was also another not heart failure directly related benefit of ARNI. And this was seen across the spectrum, and it was consistent over 24 months. So ventricular remodeling, what are the benefits? After reduction, mitral insufficiency, I said this, reduce ST2 is considered as a death molecule, increased nitric oxide and cyclic GMP, decreased AMA extension in trials, reduce aldosterone, reduce extracellular matrix, so less fibrosis, less hypertrophy, less apoptosis.